So before Kulbhushan starts, I would like to introduce him. Kulbhushan is my former fellow from SGPGI Lucknow. He is currently consultant GI surgeon and faculty member in surgical gastroenterology at the National Institute of Medical Sciences, NIMS, in Jaipur. Kulbhushan, please.
Yes. Good evening, respected teachers and colleagues. My topic is nomenclature and Atlanta classification of acute pancreatitis. So we cover this topic in first we discuss the original Atlanta classification, then what is the issues in the original classification, then we discuss the revised Atlanta classification, and then conclusion. So, okay. So Atlanta classification it was introduced in 1992, and it provides the standardized definition for acute pancreatitis, types based on severity, guidelines for severity assessment, and definition of local complications. So, definition by Atlanta classification: acute pancreatitis is acute inflammatory process of pancreas with variable involvement of other regional tissue or remote organ system associated with raised pancreatic enzymes level in blood or urine. So they define the severity in two types: in mild or severe acute pancreatitis. In mild acute pancreatitis, there is minimal organ dysfunction and usually uneventful recovery. And in CT scan, there is usually normal enhancement of the pancreatic parenchyma. In severe acute pancreatitis, there is associated organ failure and local complications. Local complications like necrosis, abscess, or pseudocyst. They define the organ failure and systemic complications like shock if systolic blood pressure is less than 90 mm of Hg. Respiratory complications if there's PaO2 is less than 60, and renal failure if serum creatinine is more than 2 milligram per deciliter after rehydration, and GI bleed is 500 ml blood loss in last 24 hours, and systemic complication in form of disseminated intravascular coagulation like platelet is less than 1 lakh, fibrinogen is less than 1, and fibrin degradation product is more than 80. And severe metabolic disturbances like calcium is serum calcium is less than 7.5 milligram per deciliter. They use the severity prediction by the Ranson score and Apache score. Ranson is more than 3 and Apache second is more than 8. So they define the local complication by acute fluid collections, pancreatic necrosis, acute pseudocyst, or pancreatic abscess. So acute fluid collection there is occur early in the course of disease, and it usually located in or near the pancreas, and there is always like a wall of granulation or fibrous tissue. In pancreatic necrosis, there is a non-viable pancreatic parenchyma. Either diffuse or focal areas of necrosis will be visualized, and it usually associated with the peripancreatic fat necrosis. Non-enhanced pancreatic parenchyma, like sir has already told, more than 3 centimeter or involving more than 30% of the pancreas area is requisite criteria for diagnosis in the CT. Acute pseudocyst is a collection of pancreatic juice that is enclosed by the fibrous or granulation tissue, and it usually takes more than 4 weeks after the onset of symptoms, and most often it is sterile. Pancreatic abscess, this is the circumscribed intraabdominal collection of pus, and usually this is in proximity to the pancreas and containing little or no pancreatic necrosis. So why we need the revision of this Atlanta classification? There is various loopholes, or I can say issues. Like it did not consider adequate parameters to define mild and severe pancreatitis. Second is like in severe acute pancreatitis, if we do the subgroup analysis, there is very different outcomes even in the severe pancreatitis. Third is like forms of acute pancreatitis, necrotizing pancreatitis. This is one of the highest mortality, but it will not characterize well or inadequately described. Like they not define the sterile, infected, pancreatic or peripancreatic or both. Organ failure was not adequately categorized, like transient or persistent. Fifth, often it was confusing to communicate between the professionals regarding disease progression or regression, because this is a dynamic disease, and it will changes according to the intervention. Sixth one is definition did not include pathophysiology, severity, and radiological description of pancreatic and peripancreatic collections. And seventh is the description of pancreatic and peripancreatic collection is confusing, that is not universal. So because of these, the revised Atlanta classification was described. It was revised in 2012, and it enables standardized reporting, which helps for communication between clinicians and for research. Offers a comprehensive classification, severity, and peripancreatic collections. It differentiate pancreatic like local complications, acute peripancreatic fluid collection, pancreatic pseudocyst, acute necrotic collections, and Waldorf necrosis. So, how they define the acute pancreatitis, in which they request two of the following three features. One is clinically, like patient had abdominal pain consistent with acute pancreatitis. We, as all know, there's the acute onset of persistent severe epigastric pain, which often radiates to back. And biochemically, when the in serum, the amylase and lipase, it at least three times the upper limit of normal value. And there is radiological third finding, in which there is a characteristic finding on CT and less commonly in MRI or ultrasound abdomen. What are the types? There is two types of acute pancreatitis. One is interstitial edematous pancreatitis, and second one is acute necrotizing pancreatitis. So in interstitial edematous pancreatitis, there is acute inflammation of pancreatic parenchyma or peripancreatic tissue, but without the recognizable any necrotic necrosis. So in CT, you can see the pancreas is enhancing well, and there is a pancreas is bulky, and there is also peripancreatic fat standing is visualized, but there is no area of non-enhancing, like no area of necrosis seen. In acute necrotizing pancreatitis, when the inflammation is associated with the necrosis, either is parenchymal or peripancreatic. And in CT, you can also clearly see there is at the neck or body part, there is lack of pancreatic parenchymal enhancement is visible. Other pancreas is enhancing well. They describe the severity in three forms: mild, moderately severe, and severe acute pancreatitis. In mild pancreatitis, there is absence of organ failure and local or systemic complications. In moderately severe acute pancreatitis, there is transient organ failure is there with or local or systemic complications. Okay, but there is no persistent organ failure is present. Transient organ failure is like organ failure for less than 48 hours. And severe acute pancreatitis that define the persistent organ failure. So, how they define the organ failure? They use the modified Marshall scoring system, in which the three organ system, like respiratory, cardiovascular, and renal, and when score is two or more than two, they considered the organ failure. Like in respiratory, PF ratio is less than 300. In renal, when serum creatinine is more than 1.9, and in cardiovascular, when there is systolic blood pressure is less than 90 millimeter of mercury, and that is not responding to fluid. So, what are the phases of acute pancreatitis? Though they are two overlapping phases in dynamic process, early or late. Early phase, which usually lasts for the first week, that is followed by the late phase, that is usually 4 weeks to month. So in early phase, this occur due to the host response to the local pancreatic injury, and this the pancreatic inflammation activates the cytokine cascade. This lead to the SIRS, systemic inflammatory response syndrome, and when this SIRS is persist, then it lead to the increase the risk of developing organ failure. Although local complications may be identified during the early phase, but they're not the predominant determinants of severity, because predominant determinant of severity is organ failure. And also, it is unreliable to determine the extent of necrosis during the first few days of disease. So it said already, sir, like the CT is not done usually in early phase. It done after the 3 days, or few studies suggest usually 5 to 7 days is a minimum limit to do a CT scan. In late phase, when there is a persistent of systemic signs of inflammation, which lead to the organ failure, and there is local complications evolve during the late phase. So you can see like local complication. We are talking about the local complication of organ failure. So late phase occurs only in the moderately severe or severe acute pancreatitis. Uh, Come to the local complications. Definition of pancreatic and peripancreatic collections. So, in edematous acute interstitial edematous pancreatitis, the local complications occur in form of the acute peripancreatic fluid collections or pancreatic pseudocyst. And in acute necrotizing pancreatitis, occurs in form of the acute necrotic collections when occur before the 4 weeks, and after the 4 weeks, when the wall is found well, then it is known as WPN, walled up pancreatic necrosis. So take one to one. In acute peripancreatic fluid collections associated with the interstitial edematous pancreatitis, and it is not associated with any peripancreatic necrosis, and peripancreatic fluid in the first 4 weeks, like before the 4 weeks. And in CT, you can see like in this film, there is peripancreatic fluid collection uh, in this and but the pancreas is normally enhancing well. There is no necrotic areas visualized, and wall is not found well. Okay, and usually this local complication resolve itself within a few days or week. And you can see in second picture that after the few days the pancreas is enhancing well, but there is no fluid is visualized in the CT scan. Second is acute necrotic collections. So this is a complication of acute necrotizing pancreatitis before the 4 weeks. So collection containing variable amounts of both fluid and necrosis. Okay, and necrosis can involve both parts, pancreatic or peripancreatic tissue. And CT, you can see there is a heterogeneous enhancement of pancreas with some areas of non-liquefied tissue and liquefied part, that is necrotic part. And there is also peripancreatic collection, necrosis is also seen. But in acute necrotic collection, same as the acute peripancreatic fluid collection, wall is not formed. Come to the pancreatic pseudocyst. This is when wall is formed after the 4 weeks. This is a continuity of acute pancreatic fluid collections. So it usually occurs more than 4 weeks. An encapsulated collection of fluid with a well-defined wall. Okay, usually outside the pancreas with minimal or no necrosis. So in CT, you can clearly see that there is a homogeneous fluid with no non-liquid component, and wall is well defined. Last is walled pancreatic necrosis. So this mature encapsulated collection of pancreatic or peripancreatic necrosis that developed after the complication of acute necrotizing pancreatitis, and usually it occurs after the 4 weeks. And CT scan, you can see the heterogeneous with liquid and non-liquid density part in both in this picture, and wall is well defined, and location can be like both as intrapancreatic or extrapancreatic. MRI is better to differentiate necrotic and non-necrotic tissue. Like in this fourth picture, it is clearly visualize this hypotense, the necrotic part, and this is the liquefied is hypertense and T2 weighted images. So, summary, like how did this revision have an impact on clinical practice? Because it avoid the confusion in terminology seen in the original classification. It also standardizes the terminology across the specialties, which helps in treatment planning, and also helps in comparison of results from different institutions. It precisely describes patient with acute pancreatitis, and it precisely describes the pancreatic collection, which is important because treatment varies with collection type. You see in the further topics. Uh, and this classification, the city helps guide management and monitor the treatment success. Thank you.
Yeah.
Kulbhushan, there are one or two questions in the chat which Himanshi has sent me. Himanshi is the technical support which is always provided to Jaipur Surgical Tutorial by Dr. Avinash Tant. He's another former fellow from the Department of Surgical Gastroenterology at SCPGI, currently at Dwarika Hospital in Ahmedabad. So, related to what you presented, Dr. Vihar Kotecha, he's one of the senior surgeons from Tanzania. He wants to know what is the duration to call it transient versus persistent organ failure. What is the cutoff?
So it's transient when organ failure is for less than 48 hours, and persistent is more than 48 hours is persistent organ failure.
And his other question is, when do you call the disease late? I don't think there is any terminology to say late acute pancreatitis, isn't it?
No, so the phase is late, but late acute pancreatitis is not described.
And Dr. Jitendra Chauhan wants to know what is the type of enteral feed which should be advised to patients, volume and timings. It is the standard feed. If the patient can take orally, you give oral diet. If the patient is having nausea or is not willing to take orally, then you can do tube feeding. And most studies have shown that there is no difference between nasogastric and post-pyloric, nasoduodenal or nasojejunal feeding. The only thing practical is that if there is a retropancreatic inflammation or collection, retrogastric, some of these patients may not tolerate nasogastric. So if the patient is not tolerating nasogastric or oral feed, then it is better to pass the tube across the pylorus, preferably into the proximal jejunum. And most of these patients will tolerate nasojejunal feed. As far as the amount is concerned, as much as the patient can tolerate, and in fact, most people would say that even if patient is in ileus, small volume of enteral feed should be given because it is well tolerated, absorbed, and also it takes care of the gut immune function and prevents translocation of bacteria. So as much as the patient can comfortably tolerate oral, nasogastric, nasoduodenal or nasojejunal feed in that order should be given. Only if the patient is not tolerating enteral feed, then one has to think in terms of parenteral nutrition. Dr. Shastri, please.
Yeah. Most of the points are mentioned. If I have to summarize, say a practical approach, now that we have diagnosed acute pancreatitis by excluding the more important surgical conditions, how do we approach this patient? The important thing is to decide whether it is a mild acute pancreatitis, moderately severe pancreatitis, or severe pancreatitis. So how do we do that? By looking for signs of organ failure or local and systemic complications. We have various ways of assessing these. A lot of scores are mentioned, but say as a practical person, you need to remember only SIRS first. See, SIRS is crucial in many areas of acute abdominal conditions, acute surgical conditions. And the organ failures, the Marshall score is the standard. You just remember Marshall score. It has only the respiratory, renal, and the circulatory components. Not very difficult to remember. You just need to know the PaO2 and FiO2 in the respiratory component, the serum creatinine in the renal component, and the hypertension and tachycardia, and whether these are fluid responsive, how long are they occurring? Are they transient or are they more than 48 hours? That is all you need to know to stratify them into mild, moderately severe, and severe acute pancreatitis. Why do you need to stratify them? Because you don't want to shift all these patients to critical care just because acute pancreatitis. If it's a mild acute pancreatitis, they would not require critical care. They can be either managed at home or they can be managed in the ward for 1 or 2 days. because sometimes you have these transient episodes, and then you would like to keep the patient on observation. So I think that is what is now. The other thing is about the imaging. When you want to do imaging, Dr. Vinay has already mentioned, within for 72 hours, there's no point in doing a CT unless you want to rule out other surgical conditions. 72 hours to 1 week. What is the indication? All severe acute pancreatitis. And if SIRS is continuing, or whether if there are signs of concern, see, some of these may not be appearing in the organ failure scores and the SIRS. Like you have a patient with comorbidities, or you have an obese patient, more than 30 BMI, or he has lung problem, say a pleural effusion and some lung infiltrates, or he has an unsettled abdomen. He has an abdominal distension with ileus. See, these are matters, signs of concern. And these are the indications where you want to do a CT for better to see whether there is necrosis, how much is the necrosis, and what are the areas. Is it confined to one area? Is it peripancreatic? Is it in the pancreas? Or is it in the right side, left side? These are, again, of prognostic importance. And if there are any complications like gas and the visceral perforation. I think these are the few points I wanted to re-emphasize in this. We'll go to the next one now. If there are any other comments or questions.
Shastri, can you hear me?
Yeah, I can hear you. You want to comment?
I just want to make a brief comment.
Yes,
I would let the people who are attending this meeting leave with a very simple algorithm in their mind. Let us not get into anything complicated. Simply remember, if it is acute edematous pancreatitis, it leads to an acute fluid collection and it leads to an acute pseudocyst. If you have acute necrotizing pancreatitis, it leads to an acute necrotizing collection and it leads to a walled off necrosis. This is all that you have to remember in the algorithm of how forget organ failure, forget everything. Acute edematous pancreatitis, acute fluid collection, acute pseudocyst. Acute necrotizing pancreatitis, acute necrotizing fluid collection, and walled off necrosis. Simple algorithm to remember the way acute pancreatitis progresses.
There is a comment by Dr. Vishal Gupta, who's watching it online. He says the current imaging-based classification systems fail to include those patients who succumb to the disease within 48 to 72 hours without giving any opportunity to have cross-sectional imaging to classify these patients into any of the existing categories. He wants some of us to comment on that. Dr. Shastri.
Yeah, see, these are unusual patients. Very unusual to have a patient dying within 48 hours. If you have not identified the SIRS in that patient and, a patient who has escaped your attention, or he is treated in a lesser facility, it is possible. But in a patient who has reported to you, it's unusual to find that kind of situation. If a patient has succumbed, I would rather think of other conditions than acute pancreatitis.
I would only say that these would be patients who are probably elderly, who have other comorbidities, who probably have a severe SIRS to begin with. So if such patients have features of organ failure, even if it is too early to classify them into moderate or severe, probably they should first be taken into an intensive care or high dependency unit. And as Dr. Shastri says, the death probably is because of the organ failure like respiratory, cardiac, on a pre-existing background of multiple. Otherwise, it's not very common to see a patient with severe acute pancreatitis dying within first 48 to 72 hours. But then imaging would not help, because if they have severe or multiple organ failure, they anyway should be managed in an intensive care or a high dependency unit with organ support. That is only thing which can be done at this stage.